All right. So, welcome to the Doctor Trainer. And, you know, just went over an interesting question on hyperthermia. And I wanted to talk about it. I wanted to talk about different types of hyperthermia, how there's a lot of overlapping features. And I'm going to try to help you with finding specific um, findings on exam or labs to help you differentiate. So, we'll start at the top. So, we have malignant hyperthermia. This is an anesthesia-related hyperthermia. This is a reaction and it's usually genetic related. So it's always important when we're going through pre-op to ask about these questions if anybody's ever had any issues with anesthesia in the past. And you can see that you get muscle rigidity, which is going to be common in a few things, tachycardia and tachypnea. So not much, but also looking at CK, so you can get a rhabdo, potentially can get hyperkalemia and metabolic acidosis, okay? And the treatment option is going to be dantrolene. Stopping the anesthesia is first, but administering dantrolene and then cooling techniques. But I'm just going to highlight on the things that differentiate at this point. Neuroleptic malignant syndrome. So neuroleptic malignant syndrome, this is antipsychotic use related. And if you stop it, you're going to have issues. This one will also have muscle rigidity. They all have hyperthermia. You get altered mental status and then autonomic instability. So your blood pressure can sometimes become hypotensive, tachycardic. But the biggest thing here I'm going to put in green is decrease in DTRs. Okay, so if you see very febrile, so 105, 104, or something like that, or above, and they're confused, a lot of these things are going to overlap. But if you have decrease in your reflexes, you should start thinking NMS, okay? You're starting to notice a lot of overlap already in just talking about two different diseases. You're seeing muscle rigidity, hyperthermia, plus minus confusion, elevated CK, because when you get rigid, you're starting to cause rhabdomyolysis. These are a lot of nonspecific findings, especially in the setting of hyperthermia. You're going to see a lot of different diseases that are associated with this. So NMS, you can give dantrolene or bromocriptine. So those are your options. Okay. You do see the antipsychotics. If they ever say what's the next best step in management, if it's ever discontinuing something, it's probably going to be that thing first. My guess is when they do questions, they're already going to discontinue it on the question stem, and then they're going to ask you what to do next. That's more important. Okay. All right. Next is serotonin syndrome. This is typically, as the name suggests, associated with SSRIs, but a lot of these different antidepressants can be affected. And this one has hyperreflexia. So all of them are going to be febrile, and maybe have some altered mental status or something like that. But I want you to be very familiar with the differentiation. These are very specific findings. If you can't tell the difference between serotonin syndrome, neuroleptic malignant syndrome, malignant hyperthermia, think about DTRs. Okay, DTRs might be normal in malignant hyperthermia, low in NMS, and high in serotonin syndrome. Okay, you're also seeing, again, a lot of these are going to have very similar findings with CK. So it might be elevated in a lot. We'll see if there's normal in some, and I'll try to figure that out with you, okay? So again, you have to discontinue the serotonin agent, and then the treatment option for this one is typically, and a lot of this is supportive care, but I'm trying to differentiate. The treatment option is going to be cyproheptadine, okay? I'm going to actually make this green. So you can see green is what I'm using to differentiate different diseases, okay? Thyroid storm. This is a really good, um, interesting disease. So somebody could have untreated hyperthyroidism, and then after surgery, all that stress from surgery or an infection will cause thyroid storm. So they may have not looked like it initially. And even people with hyperthyroidism are typically diagnosed with hypertension, but then mistakenly they're not being pursued for secondary causes of hypertension. So that's all just what we talked about here, and I already used the wrong color. Sorry about that. So untreated, but then stress and surgery. If you think of stress and surgery together for this type of patient. Um, and then, if you think about hyperthyroidism, you're going to see maybe goiter, but that's too easy for a board's question. And again, altered mental status is going to be on a lot of patients. So what I learned is lid lag is a very specific finding for thyroid disease. And typically you ask the patient to look down, and then their lids kind of are stuck in that setting. Whether it's for a long period of time or not, doesn't matter. But it's not ptosis. So ptosis is when the eye is drooping, and that's a different set of differentials. So this one, typically, they're going to come in with tachycardia, hypertension, confusion, and then if you see lid lag, if you see goiter, maybe. If you see eye changes like lid lag for this type of patient, think hyperthyroidism. So this is your typical hyperthyroid combination. And the treatment is going to be, gotta get propranolol in there. That's going to be initial best step, because propranolol works very quickly to decrease the very severe effects of thyroid storm, which is your tachycardia and hypertension. You don't want to get, from that, you can get heart attack, you can get tachycardic-induced cardiomyopathy, you can get stroke, right? There's a lot of different bad things that can happen in that setting. The PTU is going to be long-term, or not long-term, but it's going to take some time for it to work. Same thing with steroids. But if they give you those options and there is no propranolol, those would be good options. The best step in management, initial step in management, will be propranolol. Okay. Pheo. All right, pheo. I'm going to start zooming in a little bit. Let's just try to focus as we go along. Genetic combinations. So we think about like MEN2 especially. Okay. I'm putting that as a differentiation because they might ask you something about pheo. You get hypertension, tachycardia, diaphoresis. So the triad for this one is going to be these three. Okay, I'm actually going to make it in green. So these three, hypertension, tachycardia, and diaphoresis, if you see that combination, although diaphoresis is not a specific finding, with that combination, you should start putting pheo in the back of your mind, especially in a young patient with no other medical history. Typically, you get plasma metanephrines. That's going to be the first best step in diagnosis. Okay, so I'll put that here at least so you guys can see. And you typically start with, so you typically want to start with alpha blockers first. That's really important, because if they give you a question like this, it's going to be a little bit, you decide beta blocker or alpha blocker first. So alpha blocker is always going to be your first choice. And phenoxybenzamine I wrote down here, but also if you see doxazosin, that is also, oh, sorry about that, doxazosin, that is an also perfectly acceptable initial option. And so you do alpha blocker first before beta blocker. And you do both of those things before surgical resection. All right, so we're almost done. Alcohol withdrawal. What's going on here? There you go. Alcohol withdrawal, if you have seen it in the past in the hospital setting, patients who have abruptly stopped drinking go cold turkey, usually 48 to 72 hours for most patients, will have withdrawal. And the withdrawal can range. It can be tachycardia, hypertension, nausea, vomiting, tremulous, but then confused. And you're starting to see you can get fevers as well with these patients too. So a lot of these start to overlap. So you can get hyperthermia, although the hyperthermia is not as severe as like the first three that we mentioned. You might see something in the low range, like 100.8 or something like that is a number that I would think of. Not 100% guaranteed, but I'm just saying that there's a lot of overlap. You get fevers, confusion, tremors. How do you differentiate tremors from muscle rigidity, right? I mean, you got to be very careful when you're reading your questions. So this one, you're going to have elevated LFTs because they're alcoholic. They're injuring their liver. They might have electrolyte issues. And their blood alcohol concentration will be elevated, but they may not give you that information right away, okay? And the mainstay for this is going to be benzodiazepines. So you give thiamine, folate, you give hydration. If their glucose is low, make sure to give glucose in the fluids. But the mainstay for controlling this, because what can happen are delirium tremens, and they can have seizures. And you want to try to avoid seizures because if they're having status epilepticus from withdrawal, because the brain got used to drinking a certain way, then it could be permanent damage. So we try to avoid that. Okay, I'm going to waste less time on this one. Sepsis, if you haven't already been exposed to this or seen this, these are going to be your risk factors. Won't waste too much time there. And again, if you know sepsis and SIRS criteria and QSOFA and all that stuff, you're going to be looking for hyperthermia or elevated temp, tachycardia, trying to look for a source. And you're going to see elevated WBC, lactate, but again, these could be reactive. So it's important to kind of use, and this we haven't talked about this yet, but it's important to use the clinical context of the picture. Like where is the setting? Because if it's something post-op, you usually won't see this right away. If you see post-op, like immediately, minutes or an hour after, you're not usually going to see infection. You're going to see maybe the first three, like, you're going to see something like malignant hyperthermia, or if they had an undiagnosed thyroid disease, maybe see thyroid storm, that sort of thing. So you're not necessarily going to see sepsis from a post-op infection happen like right away. It might happen the next day or the day after, depending on where the infection is. You start to think about your post-op reasons for fever. So infection is one, then a wind like atelectasis or pneumonia, water, UTI, et cetera, et cetera. And then if you have to give them antibiotics, you give them antibiotics. Okay. And if you need source control, that's also important, especially if it's a surgical site infection. All right, last one, heat stroke. Thought this was an interesting one to bring up. So this was because I wanted to bring up as far as comprehensive as I could for hyperthermia, but in no ways this is comprehensive. It's just a table, but I try to do my best. And this is from high temperatures. So if they're outside in the sun, working hard, doing labor, usually like maybe an elderly male who's trying to mow the lawn and it's like 99 degrees outside and he's trying to just push through it. Those are the type of patients needing to know the difference between heat exhaustion and heat stroke. So heat stroke, they're going to have fevers that are super high. They're going to have like 105, I would think, Fahrenheit. Okay. So they're also going to have dry skin. This is very important. They're also going to be confused and they may be hypotensive. Okay. And elevated CK could potentially happen. We've seen elevated CK in a lot of patients. Hypernatremia might tell you, volume status, especially if they've been sweating, dehydrated, they're not drinking any water, they're not hydrating, they're going to get a higher concentration of sodium. And then potentially elevated LFTs. And these patients, you typically, one of the initial things that we do clinically is we'll just get a fan in the room and spray mist. That's one of the quickest ways to drop their temperatures. But then you can get like ice packs, you can get cold IV fluids, that sort of thing. But one of the quickest things you can do is just stick a fan by them and then spray them with a bottle. But at the end of the day, it's going to be rapid cooling. All right, I wanted to mention one other thing. So with thyroid, because there's a bunch of CKs that are elevated. CK will not be elevated in sepsis necessarily, depending on what the situation is. So normal CK. Alcohol, same thing. If they've had seizure, that's different, right? So this could be plus minus. But with Theo, probably going to have a normal CK. And then with thyroid storm, usually you have a normal CK. Okay? I just wanted to make that clear. All right, hopefully you guys enjoyed this. Any questions, let me know. Thank you.